Hello, and thank you for joining our webinar, Reducing Non-Value-Added Clinical Variation, presented by Vizient. I'm pleased to introduce our presenters for this 60-minute session. Our first presenter, Eric Birch, currently serves as an associate principal at Vizient, where he focuses on innovative healthcare delivery models, clinical quality processes and structures, case management and care coordination, value-based care strategies, and accreditation and regulatory compliance. Eric brings over 25 years of experience in healthcare, clinical operations, and quality, and has served in hospital leadership positions, including Chief Operating Officer and Chief Nursing Officer. He holds a bachelor's degree in nursing and a master's degree in business administration. Our second presenter, Brad Schultz, is the principal of Lean Consulting for Healthcare Performance Partners, a Vizient company. Currently serving as a Lean project manager, business consultant, and executive coach, Brad brings over 20 years of experience in healthcare consulting, including his contributions as a member of the group that pioneered the application of Six Sigma in healthcare. Brad holds a Bachelor of Science degree in business administration, a postgraduate certification in quality engineering, and a master's degree in business administration. Today's 60-minute webinar will discuss the following topics: how to link analytics, evidence-based practice, and benchmarking with process improvement, how to identify key stakeholders and utilize best practices to reduce variation in care and be successful in a pay-for-performance environment, and how to develop an implementation plan with standard work to build a successful sustainment model. As a reminder, we will have time at the end for Q&A, and we encourage you to use the Q&A panel to submit questions. And with that, I will now turn it over to Eric Birch to begin the presentation.
Thank you, Bindu. Good morning, everyone, and welcome to our webinar. I'll begin our discussion with how to link analytics, evidence-based practice, and benchmarking with key processes for improvement. But first of all, I thought I would start with a quote that a colleague had shared with me. This is from Albert Einstein. Not everything that counts can be counted, and not everything that can be counted counts. So why measure or talk about measures? Because if we want to improve, we have to measure. Have you ever said or heard your staff say, why are we collecting this data? What are we trying to measure? Is anybody doing anything with it? Or you keep seeing the same monthly dashboard with metrics that haven't moved all year. Why are we collecting it? What is the benchmark or the outcome? And what are we trying to achieve? Who's working on it? We keep presenting the same metric and I've seen no improvement. These are common themes that I see across the country as I work with our members. Organizations need to think of these questions as they collect and analyze and use the data to make change. Before we get into talking about strategies to improve the quality measures, I think we need to take a step back and really look at the quality landscape. Historically, it's been a silo approach, which has led to a lot of difficulties for our healthcare organization. First, there are different measures from each quality program, whether they be programs from registries or societies or public reporting from CMS. We all have challenges with all the different measures that are out there. And then you take that the next step, and there are also issues with reporting criteria that are different. And so each program may have a different spec manual. So as we think about how we're collecting this data, it is built in that we have some inefficiencies in that process. Up until now, there's really not been a clear measure development strategy. So the measures are developed across the many different organizations. And how do we strategize to create a system that brings together some of these common collected data elements and give us the ability to use those as we report those up through reporting organizations? Naturally, a lot of these measures are disease specific, so that inherently gives you some silo effect as you look at particular specific measures. But the other key here is, with all of these things going on in the quality landscape, it's so confusing and burdensome to our stakeholders. I think we've made a lot of progress to support better quality of care over the years. However, there are challenges that we still continue to face as we look at the quality landscape. Engaging our stakeholders in the discussions, moving forward with initiatives that actually move the needle, and truly understanding what we are trying to measure and how we are trying to affect our outcomes. Today, there are numerous and diverse quality improvement initiatives underway at all levels of the healthcare system, federal, state, regional, local, and even within healthcare organizations themselves, that are putting quality measures to use. Quality improvement initiatives with and across healthcare organizations are core to these efforts. They require measures in order to identify opportunities for improvement, often through registries that enable providers to assess how their patients are progressing and what are the key aspects of care that there may be some potential complications in order to identify those areas and use those for improvement. The other piece to quality measures is they're using them for payment reform, pay for performance, which drives organizations to implement changes and deliver care and improve care and avoid unnecessary costs or penalties, or to gain incentives depending on how well they do. I love this slide, but I think of all the measures out there, and I think that we really need to change that middle circle that says hospital to the entire system of care. Measures are no longer just in the four walls of the hospital. This adds to that complexity and the confusion for your clinicians as they practice across the continuum. So as we think about all these measures and where they come from and how they are, we need to understand, obviously, how were these measures decided upon, what methodologies were used, and how do I help my key stakeholders understand and navigate this madness. So let's start at the very beginning. Evidence-based practice, evidence-based medicine. When we think of quality measures that we collect, analyze, benchmark, or report, we can't forget that these measures were developed based on evidence-based research. Evidence is at the center of the quality measurement metric development, and of course it's defined as the judicious use of current best evidence from clinical care research in the management of individual patients. Taking that a step forward, this evidence is used to develop practice guidelines that lead to standards of care. There's more activity than ever around development of quality measures thanks to private organizations such as the AMA, public organizations such as the Center for Medicare and Medicaid, Healthcare Research and Quality. Even the National Quality Forum has taken important steps to assist us in prioritizing the measures for development and implementation, and especially endorsing quality measures to promote the consistent use of meaningful, well-understood measures. So what are the dimensions of good quality measures? What makes a quality measure one that can be endorsed and utilized throughout organizations? The first is a good dimension of quality measures are that they should be linked between a process and an outcome. Processes and outcomes are derived from evidence. They're precisely defined inputs and outputs, numerators, denominators, exclusions, and methodologies such as data source sampling, scoring, and display are key components as those are incorporated into the measurement. These measures have to be actionable, and these measures have to be tested. Why do we want to know where these measures are coming from, how they're developed? Because it's key to prepare you to discuss that data with one of your most key stakeholders, the clinician. As I travel from organization to organization, I see various degrees of clinical engagement. Many common issues I hear is, I don't trust the data. What is the population? Are you sure these are my patients? How do you measure this? Why are you measuring this? And of course, one of the biggest things I always hear is, our patients are sicker, or we're different. So as we think about the talk and strategies with our clinicians, what I find as we put data in front of our key stakeholders, it's really important that they understand where this data is coming from, how we should use this data, and they can be key in leading quality initiatives throughout your organization. Clinicians want to understand the data. They want it to be meaningful to their practice and patient outcomes. A key mistake that organizations make is presenting this data without a discussion, just popping it up on a screen, not giving them time to react. And in turn, that does lead to some delays in actually getting to the core of why the data is telling us this, or why this outcome is occurring. And we have to filter through a lot of that noise that occurs. So when you're ready to engage key stakeholders, these are some key elements that you want to cover. Obviously, what's the source of the data? When was the data pulled? What's the size of the population? Is it a certain population, such as a DRG, a service line, a particular unit, or is it broken down by a physician group, individual physicians, procedure, or a particular device or process that has been implemented in a certain patient population? The other piece that I already touched on earlier is the methodology. Clinicians have scientific mind. They want to understand the data and the actual structure of the data. Is there exclusions? Is it risk adjusted? What's the numerator and denominator? And why are we measuring this to begin with? The other key component, and one of the biggest components, is the data actionable? Is it meaningful? Can it guide you to where opportunities exist for improvement? And can you use it as a learning tool to drive the change that you need in the organization? One of the other areas that I think is really important to understand is comparative data. This could be a major roadblock when you go down a quality initiative, and so it's key to understand, who are you benchmarking this data against? Is it national? Is it regional? Is it state? Or is it like-size organization, academic versus non-academic? So all of these questions that the clinicians may have, you need to be prepared to have this dialogue and discussion. And it can take you a long way to not only moving from just looking at what the data is showing you, but to help build rapport with these key leaders that will drive the change in your organization. So these measures are based on evidence-based practice and standards of care. So why are we still struggling with outcomes? We adhere to the bundles. It's in policy and procedure. We've educated the staff, but we're still not hitting that outcome that we hope to achieve. What's missing? The key here is most organizations struggle with the implementation science of how to take these practices and move them to a standard work. And so I hope that during the remainder of this discussion, we actually provide you with some key insights to think about that as you move forward. So if you look at this slide, I want to give you some key takeaways of things that I see where there's successful initiatives and unsuccessful initiatives. The first square, the green one on the left, these initiatives should be driven by clinical leadership. I'm sorry, that's actually on the right. These should be driven by should be driven by key clinical leadership, not driven by information systems. Data shouldn't just be a report that's sent out to everybody, allowing individuals to work on improving those key metrics in their areas. There should be a structure for improving initiatives, aligning your clinical leadership into initiative champions, ensuring that they have the support of key leaders to remove roadblocks, engaging those that are directly involved in the process, and including those with the knowledge and expertise to help drive and sustain this process. The other key piece to this is a member of this team should also be very well versed in implementation science and can help guide and lead the entire structure as you move through initiatives. The next component obviously is data. An unsuccessful initiative uses data as a weapon. Unfortunately, I've had the pleasure, I don't know if it's the pleasure, of actually being in a meeting where nobody has seen the data and it's been held to someone's chest the entire time, and then it's presented in front of a room that really shows poor outcomes in certain areas or by certain people. and it almost feels punitive in nature. Data should be used as a learning tool. We need to take this data, identify what is driving our results for our outcome measures. Are there key leading indicators, such as things that if we do it right, it's going to lead to better outcomes for our outcome measures? And if so, how do we include those in our implementation strategies to make this happen? So data should never be used punitively. It should be shared globally. It should be used to drive change. And it should be something that is in front of everyone. The other thing that happens is sometimes the data is on individual computers, or is only in the quality department, or is only on a particular unit, or is a particular registry that only the cath lab uses. The key here is we really need to realize that we need a data warehouse. And the value of that early, putting that data together into a common area will allow other clinicians to tap into some of those data sources, take a look at what is being measured, and identify strategies for improvement throughout the organization. The other thing that can happen in these processes is people get stuck in designing and planning phase. The key here is do your homework initially before you start the initiative, using root cause analysis, observations of key processes, identify of all these measures or all of these leading indicators, what is affecting our outcome measure. So for example, and we'll talk about this in a little bit, I'm going to take CLABSI. So a CLABSI can occur whether it's an insertion or it is a maintenance type issue related to CLABSIs. So if you're looking at all the causative factors, using root cause analysis, taking a deeper dive into the data, looking at key observations, you can identify those leading indicators that may affect your outcome, such as the dressings are dry and intact. Well, no, they're not. We're having a problem with occlusive dressings. Or we're not scrubbing the hub as we said we would. So those may be two key indicators that would drive your ability to affect your outcome measures. The other key thing is missing key stakeholders. If you try to design something in a vacuum, you truly aren't going to have the results unless you incorporate your key stakeholders in the organization. If you're driving nursing practice on a floor, engage those nurses on the floor. If you're driving change with insertion practices for central lines, engage those physicians and professionals that are doing those insertions. So it's really key to think of that. So for the remainder of my talk, let's walk through some important, very key aspects of how to improve your quality initiative strategies to ensure that you're successful. So let's talk about the steps that we need to consider to have measurable and sustainable improvement. First of all, it's prioritization. We know there are a ton of metrics out there. We're collecting this information. We're either mandated to do it or we want to do it to improve change. There's so many things to focus on. How do we do it? First of all, look at your performance. Identify those areas that are not meeting the benchmark. That will hopefully narrow those down significantly for you. And then prioritize them based on harm and patient outcomes. Decide what is system-wide, what's department or service line specific, and ensure that you align your resources around these initiatives based on what you're trying to achieve, how big the scope is, and what is truly driving the reason for wanting to go after that. Obviously, patient outcomes is a key driver. There's also opportunities around cost containment or even improving your performance in certain key measures that will align you better for your strategy as an organization to grow. The next key piece is utilizing benchmarks to set goals. Take those benchmarks, do a baseline, draw a line in the sand. So once you've done your baseline, let's draw that line so that we can understand as we implement intervention, we can see what is actually moving the needle. In organizations where I see quality professionals throw many interventions at a particular issue without drawing that line in the sand, we wonder, okay, of all of the 38 things we did, what ones actually move the needle? And if you think about it, if you have your organization trying to collect data measures for 38 leading indicators so that your lagging indicator improves the outcome, that's a lot of work, and it's a lot of busy and unnecessary work. The other key is use the drill down and focus improvements to understand how and why we're having these results. When you focus your improvement efforts, understanding what is causing these things, it can really impact your ability to identify defects and determine where you should focus your improvement. And then, of course, the last one, which is, as I think about it, it is why we're here, what we're doing, what we're talking about, is evaluate your progress. Using those leading indicators are great to ensure that you're getting compliance with the intervention. It's a way for leaders to continue to evaluate the progress, to make sure that what you're collecting is meaningful, and to sustain the work that you're doing, which would lead to standard work that will then allow you to have those outcomes or those lagging indicators that you're trying to achieve. So in the remainder of time that I have left, I just want to walk through an example to consider as you embark upon process improvement. In particular, let's take a look at reducing hospital-acquired infections, in particular, CLABSI. We have had bundles and measures for CLABSI for a very long time now. It is very good evidence-based practice. But as I am with members or as I look at issues around organizations, a lot of people are still struggling with having central line infections in their organization. This slide is actually some quotes from a panel that was published in the Infection Control Today, where the panelists were very clear that the recommendations are very sound. They're very evidence-based. They make sense. We believe they should happen. But what is our disconnect? We can't get these recommendations into standard work or into practice. So it really is very telling that there's a clear need for organizations to think about the implementation science behind moving the needle. In particular, this will be for hospital-acquired infection, but that can go even further to any process or measurement that you're trying to move. So let's take CLABSI, for example. This slide here really just talks about or gives you the step-by-step things that you should do to really try to drive change in your organization. The first thing is, okay, my organization, I know that I'm having a problem with CLABSIs. It's not where we want to be. We would prefer to have zero. So let's brainstorm on what are the causes of CLABSI. That's where you're going to take any RCA you're doing when you have a CLABSI occur, observations of the process. Hey, let's go up to the floor and actually let's audit all of our central line dressings. Are they occlusive? If we're using a Curos cap or scrub the hub, let's see how that's occurring. And do we have caps on all of our hubs? What's our flush protocol? And do our nurses even know it? Should we ask them? The other piece to that would be, okay, let's look at insertions. How are our central lines being placed? Are we following the checklist? Do we have the right supplies and things that people need to not only insert it, but then maintain it after it's inserted? And then another question is, do we truly even need this central line? So as you're brainstorming and thinking about all of that, you're going to engage your key stakeholders. Your clinicians are what are going to help drive this process. So you're gathering all this information. The next step is, okay, we have all of this causes or potential causes. Let's put that through a process, either using a funnel chart or a fishbone diagram, a cause and effect tool that really can give you just a key understanding of if we're doing this, this is the result. And then take those and actually begin to prioritize them or rank them. This is really important as you take a list of 30 some odd recommendations to prevent CLABSIs in your organization and narrow it down to why are we having CLABSIs? We probably are doing 35 of those great, but we have 3 that are not going so well. And we've got to figure out how we can change our practice to ensure that these occur. So doing prioritization, doing a ranking exercise is critical for those variables. The next step obviously take what you learned and build a project charter or an A3 charter. This will allow you to begin organizing. Why are we focused on CLABSIs? What is the impact if we could eliminate them? Let's calculate the clinical and the financial impact so that we can celebrate when we get to 0, we have no mortalities related to CLABSI, that we were able to save the organization on the cost of care for a CLABSI, or even impact your pay for performance metrics and avoid a penalty. It's always important to think about those things as you pull together a charter of why we're doing this, what we're doing it. The other key to this is, since you've engaged some key stakeholders, identify those champions that would be key to driving this through your organization. The next step is brainstorming improvement activities. This is a time that you pulled your group together, you have an aim, you have a purpose, you have goals in mind, you know what is causing these issues. So let's build an implementation strategy that helps us address that. So you've got this charter, you've got a plan. The key here is, how do I put this together in a format that gives me the ability to continue to monitor it, to report that to our key stakeholders and our leaders, and to keep everyone's eye on the ball? A great way to do that is implementing a status A3. It's a great report that can capture your activity and your improvements, as well as measure your key indicators, whether they be leading or lagging indicators. So I'm just going to walk through this particular organization that we worked through. We went through those steps. We found that they were having an issue, in particular with CLABSIs around maintenance, which is very common. I think I saw where 80 to 90% of most CLABSIs are caused by our maintenance issues, not insertion. So as we looked at this organization, we did audits, we looked at the root cause analysis, we identified that there was 90% of our central lines had an issue with dressing being dry and intact. The hubs were clean. This particular client used Kuros caps, so we were looking for those green caps on every one of those. And so it was very easy to spot our defects in the process. The other thing that came next was, not all nurses knew the line flush protocol. Even though we had it in policy and it was implemented, there were still some challenges around that. So as you think about what your leading indicators are and what we want to collect and measure, those are two key important things that we identified with this particular organization on what needed to happen to make this, to make these changes. So taking that a step further, it's thinking about process measures. Those are processes that we want to make sure occur every time with any patient that has a central line. So those are our leading indicators. We know that if we do these, the downstream effect is that we are going to have a reduction in CLABSIs or 0 CLABSIs based on what we did through our analysis and our collection of causative factors. So if you think of the 80-20 rule, in here it's more a 90-10 based on this, this organization. We need to figure out how can we audit compliance with this. Because when we go back to the very first slide I talked about, you want to measure what you're trying to move. So we think of, oh no, not audit. We as organizations tend to take a bundle and want to audit everything on that bundle. Some of those bundles are very complex. We can end up with 36 things we want to measure on certain things. So it's really important to identify those key indicators that we want to monitor. So for this particular organization, we wanted to look at, is the dressing dry and intact and occlusive? Is the hub scrubbed, or does it have a Kuros cap on it? Are we complying with flush protocol when we flush these lines? So in order to do that, we had to go to the bedside. There's no other way to do that, to really figure out how to do some audits to ensure that we impact the change or that the change is occurring. I know everybody's saying, no, we don't want our bedside nurses auditing, they need to do care. But I think it's really important to think about that we want to do great care. And there are alternatives to auditing certain key processes. Some organizations, and this particular one, actually included their charge nurse who happened to be free-floating. Not everybody has that. And then some even use their unit clerk and train them on what it should look like in order to audit certain key processes. If you're looking at scrub the hub and you have a Kuros cap, they're going to look for green caps on all the hubs. So they're able to measure that compliance. The other key thing is we want to engage those key specialists. Infection preventionists are great to go around and support those audits to make sure there's compliance with the audits, that there's accuracy with the audits. Quality staff is another one. And then, of course, our leadership. Leadership is key to driving change and sustaining change. One thing I want to talk about when audits, what I think is important, and this quote is, an audit is conducted not to measure the compliance rate, but to change practice at the point of observation. If a particular unit is not achieving 100% every day, that's not something that should be punitive. If they started off at 80 and have progressed up to 95 and then on to 100%, we should celebrate that. And if they continue to hit 100% over a period of time, do we need to decrease the frequency of how often we're auditing? However, if we do see that they've been 100% compliant and now they've seen a drop, it's time to refocus and increase the amount of auditing that is going on again. So auditing should not be punitive. It should not be, oh, we're doing this because we just want to measure something. These measures that we identified using a leading and lagging indicator are key to driving change in the organization. This happens to be actually a charter and an example of one. This gives us one document that really summarizes what we're trying to achieve, where we're trying to go. It measures the impact if we were able to eliminate CLABSIs. It measures the key outcomes and process measures that we want and gives us a goal and then shows progress as we move forward with this. You can turn this into a status A3 that is used weekly in your leadership meetings or in your meetings on your units. It is key to allow you to not only show movement, but also you can add a section where you're looking at compliance with your implementation plan or the status of your implementation plan. And it gives you a great one page for people to look at to understand what's going on with your particular initiative. So this happens to be the daily measures that were put in place to look at Curos CAP compliance for this particular hospital and central line dressing compliance. The key here is trying to make it as simple as possible, taking the number of central lines and then the number of central lines where dressings are intact and the number of central lines where the Curos caps are on all of your caps. So as we look at it, obviously when we started the initiative, we truly wanted to measure what is the compliance rate. So as we worked with those auditors, we wanted them to truly measure this. It was not going to be used as punitive. We're not going to slap hands. We didn't want them to go in and say, oh, there is a problem here, and call the nurse and say, fix this and I'll mark you 100%. Because we wanted to really impact the change and make this happen. And through that auditing and posting this on the units, the nurses knew this was important for them to look at and to address, and really understood that the bottom line was taking it to an outcome measure and identifying, hey, we did this and then it resulted in no CLABSIs. So it's key that you not only measure your leading indicators and your compliance, but then tie that to your outcome measures of hopefully no CLABSIs or a significant reduction in your CLABSIs. And this is an example where here's your baseline, this is where you were. Draw that line in the sand and then begin collecting that based on the intervention. If you don't see any movement, it's time to revisit those interventions and see, did we truly capture what's really driving this? Let's look at those CLABSIs that we had after we implemented this practice and take a deeper look to a RCA, identify, hey, we're missing something here. And that would be key to moving to your outcome measures. So as I wrap up my dialogue, and I know this was quick and very fast, and there's so much that can be discussed on how to impact using analytics and evidence-based practice to achieve results, I just want to take just a few things as key takeaways for you. One, engage your key stakeholders in quality improvement. Don't just put numbers up in a dashboard or ask someone to collect something without truly giving them the background, giving them why we're doing this, and making sure that it's key to really identifying and building an implementation plan for performance improvement. Select measures that move outcomes. Process measures, outcome measures, we know that we are required to report something, but we report things because we want to reduce harm, improve outcomes for our patients. So what processes are out there that we can actually take and move forward? And then, of course, ensure that initiatives are aligned with organizational priorities and lead to the development of standard work. So I'm going to turn it over to my colleague, Brad Schultz, to continue the discussion, and he's going to cover driving unwanted variability out of processes. Brad?
Thank you so much, Eric. You know, most organizations that embark on the initiatives that Eric described in his presentation are really doing it not just for the sake of doing it, but really to improve clinical outcomes, improve patient satisfaction, and reduce cost. In other words, create more value for the patient. And if you think about it, the systematic elimination of unwanted variability from our processes really makes us more reliable. So I thought I'd start with the definition of reliability. And many organizations are striving to achieve that status, high reliability organization. You know, a quality of being trustworthy or performing consistently well. So if we have a tremendous amount of variation, that's kind of the antithesis of high reliability. So the first question I would ask you to ponder as I go through this presentation, would you characterize your organization as a high reliability organization? And to give you a yardstick to kind of compare to, high reliability organizations are preoccupied with failure. They actually systematically seek out, using data and observation and other techniques, where the weaknesses in their processes are and put mechanisms in place to prevent that from becoming a source of unwanted variability. They have a reluctance to simplify. They understand that our environment is complex and it's adaptive, and that we really need to understand at a deeper level before we take things in a very reductionist approach. They have a profound sensitivity to operations. This means big picture rather than a siloed look at things. Often when I fix something in one place, I break something somewhere else. So there's, within high reliability organizations, a very profound sensitivity to operations. There's a deference to expertise. You know, the people who actually do the work have the greatest knowledge. And in many cases, if during Eric's presentation, he talked about this really takes us to the bedside. We have to be measuring and observing this at the bedside. That's a much more enlightened approach to improvement than getting a team in a conference room on a surreptitious basis. They also have a commitment to resilience. They understand that things change. Conditions change, the environment changes, and that drives things that we previously hadn't predicted. And we have to be in a position where we can understand them as they happen, when they happen, where they happen. So that's kind of a good thumbnail sketch of a true high reliability organization. Now, the challenge in this is that organizations, just like everything else, are subject to the second law of thermodynamics. There's this tendency towards entropy, this tendency towards chaos, which really means we have to put energy into the system in the form of time, effort, and investment to keep it organized and to really achieve that high reliability state. Now, often the return on investment for that is substantial. And by being structured in how we approach that, this can be not only a cost neutral situation, but actually a cost beneficial situation. So I want to talk about two of the most powerful tools that can lead an organization to that high reliability status. The first is standard work. And standard work is really a clear, concise, written description of how to perform a particular process or a set of tasks so that the outcome will be safe, efficient, and the highest quality. It represents the best known practice at a point in time. And the two things that I would emphasize in this definition is, one, best known practice. We should be continually experimenting with better ways of doing things on an ongoing basis. And when we find that better way and we prove it works, that becomes the new standard. The second is written. There have been many times I've observed processes in an organization and saw what I thought was an abnormality and asked the people I was observing with, do you have standard work that governs this process? And they'll tell me, yes, it goes like this: step 1, step 2, step 3. And I'll say, could I see the document that governs that? Well, we really don't have a document. So in that particular case, what you really have is tribal knowledge. It's not standard work. The really critical thing about standard work is if you start with a simple 3-step process that leads to a single outcome, but I have 5 different ways of doing step 1 and 5 different ways that follow on each of those for step 2. By the time I get to step 3, if we go 5, 5, 5, I've got 125 potential outcomes. And in that situation, outcomes are really no longer predictable. They're a matter of random chance, and that's actually the antithesis of high reliability. The other thing is, as organizations go through improvement efforts like Eric described, many organizations do ongoing PDSA cycles trying to improve their work. Without standard work, it's very difficult to hold the gains. I know all of you have seen situations where we improved a process, and over the next 6 months, the needle just drifted right back to where it was. So standard work's really a powerful tool in preventing that from happening. The next question I would ask you to ponder is, where is the abnormality in the picture that I have on the screen at this moment in time? Which one of those objects is abnormal in relationship to the others? Now let's take a look at this screen. Which one is abnormal in relationship to the others? And the key here is we really cannot see abnormal until we've defined what normal is. And that has some very profound consequences. If I'm not able to distinguish abnormal from normal right now and respond to it right now, then the further I get away from the problem in both time and space, the lower the probability that I'll actually identify root cause. And the higher the probability that this particular set of circumstances will eventually cause harm. So this is an example of a standard work document that governs a hospitalist visit with the patient. It was put in place by an organization that was looking to achieve a higher level of service excellence. And the key thing in this is that it defines the content, the sequence, the timing, the location, and the outcome. And it also emphasizes the key points and the reasons for that. And one of the things that, I've been accused of in doing this kind of work is, Brad, you're promoting cookie cutter medicine. But the idea here is we recognize every patient is a unique individual and that our work has to be customized to the individual. But standardization is highly misunderstood. It's actually an enabler of mass customization. I think everybody on this webinar probably has a PC, whether it's a laptop or a desktop. On your PC, you have a device called a USB port. What can you plug into that? And a better question is probably, what can't you plug into that? You can plug virtually anything into that, enabling to use your computer millions of different ways. And that customization of the use of your computer is only made possible through standardization provided at the USB port. So it's really not the promotion of cookie cutter medicine. The other thing too is, let's take a very simple process like implementing an IV. Is it important to prep the site? Most everybody would say yes. That's an example of the content being important. Is it important to prep the site before we implement the IV? Again, yes. That's an example of sequence being important. Can we implement the IV just anywhere? Of course not. That's an example of location being important. Does it matter if the person implementing the line implements with their left hand or their right hand? No, it's not. So we don't standardize there. And the idea is we only apply standardization in those cases where the content, the sequence, the timing, or the location impacts the outcome. And that's how we avoid this whole concept of cookie cutter medicine. Excuse me. So a few more questions I'd have you ponder with regard to standard work. How do you distinguish between variation and a defect? All processes have variation in them. And from the industrial engineer's perspective, they come from two sources. What we call common cause variation, we really can't identify why that variation is there. And assignable cause variation. An assignable cause, we can assign it to a cause, and it usually has a negative effect on the outcomes. So if you think about driving down the road, you know, you can use the left side of the lane, the right side of the lane, the center of the lane, but you need to stay in your lane. And the right side might be defined by a curb, so it's pretty clear if you got out of your lane. And that goes beyond variation to the world of defect. But if you go to the left side and there's just a painted line, that may be a little less obvious. So what defines a problem then? And these are just questions I'd like you to ponder as you take away from this experience. And if you have no standards, you have no problem, right? Because in order to have a problem, I have to have an intended outcome and an actual outcome and a gap between the two. So if I have no standards, I have no problems. And no problem is a very big problem. Another tool that is very powerful in achieving high reliability organization status and eliminated unwanted variability from processes is mistake proofing. You may have heard this referred to as POCIO. It's really a process of systematically identifying potential causes of errors and putting mechanisms in place to physically prevent it or at least draw attention to it. And this concept was really developed to a great extent by Shigo Shingo. So those of you that are familiar with the Shingo Prize, he was chief engineer at Toyota back when this was being developed. And just a trivia item, he originally described it as bakayo, which means idiot proofing, but I think mistake proofing was a little more politically correct. And mistake proofing really occurs on a continuum. So there's things that we can do to prevent mistakes that fall into three categories. We can either create awareness. So everybody's got an awareness of what's right, what's wrong. And that usually occurs through instruction or providing visual aids or providing visual controls. Better yet and more powerful is something that alerts us to the fact that an error has occurred. That's a better approach, and you can bundle those as detection, the ability to detect. And finally, the most powerful means is to make the mistake impossible to happen. A good example, it's very difficult you would have to get really, really creative to connect nitrous to a patient's oxygen line in an OR. The fittings just won't fit. And that's a good example of, you know, achieving a true state of mistake proofing. So I've included in here, I'm not going to go through all of these given the time that we have, but I've given a few examples here, and I'd challenge you as you go through these, where on the continuum does this fall? You know, ideally we're striving for the right side of that continuum that I described. But barcoding is probably the one that most people are very familiar with. It's a very effective way of enhancing the process through correct identification. Another one that I think is very powerful is unit dosing. This actually combines two techniques, robotics and barcoding, and packaging of medicines in plastic bags in a single dose format, which is a very powerful combination. It makes it very difficult to get it wrong. The other thing that I would emphasize before I come to a close here is that a system is really an interdependent group of items, people, and processes with a common aim. So none of this is really happening in a vacuum. So again, as we apply standard work and as we apply mistake proofing, we really need to think of the consequences on both our upstream and our downstream partners as we go through this. And, you know, Eric talked about auditing, and I want to touch on this for just a second because a lot of people, when they hear auditing, they're like, oh, you get that sigh. But actually, a key concept associated with mistake proofing and standard work is what we refer to in the industrial engineering world as built-in test. In other words, if I have a lot of people going around with clipboards and pens auditing, it's a waste of time. But if the first step in my process, upon receiving a patient, receiving product, service, or information, is to verify that it's accurate and complete, I've actually done the audit in that moment in time. And if I have some type of tally sheet in my pocket that I can mark it down on, what I've done now is I've taken it out of the world of clipboards and pens and into what I refer to as the natural stream of work. So with that, conclude my session and turn it over for Q&A.
Okay, we have time for a couple of questions. The first one is about process improvement activities. Specifically, how do you select the key stakeholders to engage for process improvement activities?
Do you want to take that one, Eric, or shall I?
I'll be glad to. And Brad, you're more than welcome to weigh in as well. The key thoughts around selecting that key stakeholder is obviously who's close to the process or the measure you're trying to move. In organizations, we know that if it's a clinical measure or a clinical process, key champions around that are your clinicians, ones that can influence the process, remove barriers, and be able to communicate effectively with all people in the organization. The other thing that I would recommend is if you have those naysayers or those that are going to be barriers, engage them as key stakeholders, put them in your process, allow them to help identify why are we breaking down, what's going on, and how can we move that and improve that. And I've seen time and time again where those people who feel that these are going to be our naysayers, they're not going to want to change, really embrace that change and become a champion for you. Does that happen every time? Not always, but if it doesn't happen, then you always use your strong clinical leadership to help mitigate those type of issues or discussions with those people. The other key people that I would definitely say as key stakeholders are the experts that you have within your organization, whether they be process improvement experts, whether they be subject matter experts. Those are always key to helping you do those analytics, make things happen. And then, of course, the biggest key stakeholder that I can think of is who's actually delivering that process or doing that care. Those are so key. Brad, did you have other comments that you'd like to make?
Yeah, I think you covered it. I think you covered it very well. I'm always asking myself, who's my Army, ARMI? Somebody has to approve the improvements, and that may be more than one person, so they're definitely in the stakeholder group. There's resources, that's the R, that I have to pull on in order to make the change happen. I don't need them all the time, but I got to pull on them from time to time to make it happen. M is my members. Those are the people that actually do the work, that are going to live with this process day in and day out. And I is the people I have to keep informed along the way. And that group constitutes my stakeholder group. And, the inform is predominantly my upstream, downstream partners who are going to be impacted by the changes.
Okay, and our final question is, how do successful hospitals make visible the written standard work to the myriad of employees distributed throughout their organization? How do you make it easy to recall or see or find or use?
So there have been a variety of approaches to it. The first is that unless it's documented, we don't have it. So that's really the first step. And then depending on the critical nature of the standard work, in some cases, I've actually seen it posted in places where the work actually happens. In other cases, we most definitely want to work from it as our number one training aid in the training, retraining, and ongoing development of individuals coming into the organization and advancing in the organization. And then finally, we always want to have it available as we're going through any type of PDSA activity or any type of group problem-solving activity.
Excellent. That is all the time we have for today, so thank you all for joining us here. Thank you, Eric and Brad, for your insights on reducing variation. And for those interested in accessing a recording, we'll be sending an email to you with instructions on how to get that as soon as it's available. And be sure to save the date for our next webinar in this series. It's the final one around optimizing service line performance. The email with registration instructions will be sent to you tomorrow. And on behalf of Vizient, I thank you for your time, and I hope you have a great day.